Patients too often fall within the gaps in healthcare, especially in this very vulnerable time between the point of discharge from the hospital and the time they see their primary care physician for the first time. So we came up with the idea of the Primary Care Resource Center, the PCRC, which would be a hub located within the hospital where nurses and pharmacists, specially trained in care management, could actually coordinate the care for these vulnerable patients across discharge and then support the needs of the primary care physicians. We really wanted to put a dent in the 30-day all-cause readmission rates for 3 specific diseases, and they were heart failure, chronic obstructive lung disease, and acute myocardial infarction. We have found in our research trials that those were the 3 leading drivers of 30-day readmission rates in this community. And looking for worthy candidates to join this project, we found 6 terrific hospitals, which were Wheeling Hospital, Uniontown Hospital, Conemaugh Memorial Medical Center, Indiana Regional, Butler Hospital, and Sharon Regional. They were the ones with the courage to step up and join us.
Indiana Regional really wanted to participate in the PCRC project because we needed to do a better job in managing healthcare costs. So we've seen that so many patients are being readmitted or coming to the emergency room, and that there's real gaps in care in the transition from the hospital to the home or other setting.
And as you know, Medicare identified readmissions as one of the major focuses throughout the United States because of a reported 20% readmission rate for Medicare beneficiaries. PCRC model gave us the opportunity to address readmissions in a completely unique way.
Healthcare is clearly going rapidly towards a population health approach, and the importance of managing those disease states so they don't come back for readmission, so that we keep our family members and our community healthier.
There's a lot of readmission programs, a lot of literature out there about readmissions, but this was really the first thing that I have seen that put it all together in a nice package, and it's really worked for us.
The one thing we had to do with the work that we do at the PCRC is to make it standard. We came up with something called the Perfect Discharge Bundle. What were the 6 things, validated in others' research, that we know contribute to a better outcome? First thing, every patient at admission would have a root cause analysis done. Why did they come to the hospital?
There's a gentleman in 503B came in last evening. He's acute exacerbation of COPD.
Second, every patient had to have 30 minutes of bedside education, unhurried, with a skilled caregiver.
Then you know it's from the Lasix. First thing I check is my sugar.
First thing you check is your sugar. That's excellent.
Some of the current conditions that the patients have to be faced with now, a lot of them have to be their own advocates. They have to become their own nurse, their own doctor. We assume that they are understanding regimens of medications at certain times a day. We're putting a lot on the patients now.
But if you look here, there's also a counter here.
So what the PCRC does, they establish at least 2 visits there. They introduce themselves, enroll them into the program, and then after that, they will go back and do education.
I wanted to take some time and review all the changes you've had.
The PCRC nurses love this because most people that go into nursing, they want to have time with their patient. They want to sit down with them. They want to teach them.
Third, we wanted every patient to have access to a pharmacist.
Over half the population has chronic illness, and of the prescriptions written, 93% of them are for patients who have chronic diseases.
Well, I know I have a water pill in my high blood pressure medication.
That water pill is going to help your body to get rid of that fluid.
With all hospitals, the time that the patient is discharged and what you want them to be home on, by the time they get home, there's always some confusion.
So you always want to keep an eye on that so that you're sure you're not going to run out of it.
The pharmacist does a comprehensive medication review for every patient. It's where they look at the optimization of the medication therapy. Are they on medications they don't need to be on? Are there medications they should be on that they're not on?
Prior to this department, there really wasn't the opportunity for patients to have direct face-to-face consultation with a pharmacist.
Fourth, every patient had to have an action plan that was thoroughly worked out with the patient and the primary care physician before discharge.
Hey, I just wanted to go over a couple of things with you because I know that you're supposed to be leaving later today. We talked about weighing yourself every day. And when are you going to do that?
As soon as I get up, after I go to the bathroom, then her and the team were just great. I wouldn't have understood anything. I would have went home and went back to my usual routine and probably would have ended up back here within a month.
Fifth, that action plan will be communicated to the primary care physician within 72 hours.
Hi, Dr. Buck. I'm calling from the PCRC. I need to schedule a follow-up visit for one of our patients who were just discharged from the hospital. She was in with heart failure.
They reach out directly to the primary care physician office to tell what issues they've identified, what questions have arisen, and what opportunities for continued education this patient may specifically have.
Absolutely, I can fax you the FRED and the discharge meds.
6, every patient will get a phone call within 72 hours, just checking, did they make the transfer to home successfully and safely?
Typically, you'll walk into a patient's room, you say, hey, you're doing great, you're going to go home, you're explaining to them about their disease process, and they are not listening to you. They are thinking, how can I get my family member to come here? Can I afford these new medicines? Am I really ready to go home?
When they get to their home, they have the opportunity to realize what questions they may have.
So I have that your MDOR was increased from 30 milligrams a day to 60 milligrams. Okay, do you take that in the morning before you take anything else?
We said those 6 items had to be done every time on every patient without exception.
I just can't really put it into words. They're fantastic.
We're teaching the nurses in the PCRC about population health, and not only to look at the patients within the 4 walls of the hospital, but to follow those patients outside the hospital, know the resources in the community that you can pull in to help those patients and support them.
The home visits are important because you get to see the patient on their home turf. Hello, how are you? It's good to see you again. Yeah, it's been a long Jim, I know we've been talking to you more, and Laura had talked to you, I know, about a couple of your medicines.
You get too many doctors going here, it's hard to get them all to...
Our goal is to prevent not only the 30-day readmissions, but to make sure they know how to manage their disease process at home.
I call Laura and she gives me the whole works.
Okay.
Explains everything out.
And I'm always happy to do it. I'm glad you called me. That's what I'm here for.
The thing we know looking at our data is we have had an impact.
30-day all-cause readmission rates for the 3 target diseases have fallen 25% since we started the program.
There is no question that hospitals that chose to participate in PCRC made a leap of faith. There is no way to pay for these services under the current model.
Wheeling Hospital has chose to maintain the PCRC because of patient satisfaction. It's helped with everything from severity of illness, reducing mortality rates, enhancing the quality of life for patients. And patients, that's the bottom line. We want to help patients as much as we can.
We're really starting to see the needle turn on our readmission rates, especially within 7 and 30 days. We're really starting to see those numbers start to go down. So it's making a difference.
Curiously, we found that the number of visits with primary care physicians for PCRC patients increases over comparison cohorts. So we're connecting patients with their physicians, and believe it or not, that's lowering costs.
To date, we've shown that the 90-day cost of care after patients leave the hospital drops by between $1,000 and $1,500 for each Medicare beneficiary.
We think that the pharmacist may be helping prevent needless duplication of medications. Maybe we're seeing more use of low-cost generics. And most importantly, patients are no longer purchasing and billing to their insurance company medicines they don't need. The thing we're enjoying right now as we're at the end of the grant is the hospitals are telling us what their plans are going forward. Everyone is making a change to the PCRC concept. They're keeping the core structure, but they're adding new diseases. They're looking at different gaps that are unique to their community that they plan to fill with the PCRC. And that's the kind of healthcare innovation we always wanted to see in this region. It's finally happening.